Hello, everyone. I think we're going to get started. On behalf of the AAMAC staff and board, I'm very pleased to welcome you to our Patient Education Day here in Vancouver. My name is Fiona Lewis, excuse me, and I work part-time with AAMAC as a patient support liaison. I'm really glad you all came out today, and I also want to welcome some people who are joining us on Zoom. AAMAC is a leading funder of research into bone marrow failure diseases in Canada and supports patients and care partners across the country who are living with aplastic anemia, myelodysplastic syndromes, and PNH. We also advocate for patients, as you may have seen in the recent news coverage about the BC government's decision to not fund luspatercept here. Two patients from our organization and our executive director, Cindy Anthony, were featured in this coverage, and we are going to continue to advocate on this issue. In addition to events like this one, we also offer monthly patient support meetings via Zoom, and patients and their loved ones are free to join these meetings anytime. Please check out our website to register for any of them and also to print off a number of other resources we have there. And we also have recordings of all our webinars, which you can watch. I do want to thank today Elar Tana, where did she go? Oh, there she is, who's joined us from the Leukemia and Lymphoma Society. Thanks for being here today to share all your materials. So I'll now introduce our first speaker, Dr. Tom Neville, who will discuss new treatment paradigms in PNH. Dr. Neville received his MD from the University of Toronto in 1983. He did an internal medicine and hematology training at Dalhousie University in Halifax, then a leukemia BMT fellowship in Vancouver. He founded the first BMT program in Atlantic Canada in 1991 before returning to the University of British Columbia in 1996. He is a clinical professor at UBC and is on active staff at both Vancouver General Hospital and the BC Cancer Agency. Dr. Neville has been the clinical director of the Leukemia Bone Marrow Transplant Program of BC since 2006 and maintains a research interest in bone marrow failure, graft versus host disease, and paroxysmal nocturnal hemoglobinuria, PNH. Welcome, Dr. Neville. Thank you.
Thank you very much. That's a very long introduction, and I'd like to I'd like to shorten it just as a really good guy. So today I'm going to talk about PNH and its relevance to AAMAC. I always show disclosure slides because we're supposed to, but I certainly have had involvement with many of the companies that deal with medications for MDS, aplastic anemia, and PNH. So first of all, what is PNH? And it's not all that straightforward, but it is interesting. So PNH stands for paroxysmal nocturnal hemoglobinuria, and it was first described by Dr. Paul Strubing, a German physician, in 1882. He had a 29-year-old man who, in the morning, he would void dark urine, as shown there, what we often will call Coca-Cola urine. They didn't have Coca-Cola back in 1882, so I couldn't call it that. And he proposed that perhaps there was something happening at night, that the red cells were being destroyed at night, what's called hemolysis, so it's an important term, when the pH in the blood becomes more acidic, which is very astute of him. So this is what happens at night. Circled at the top, there's this very careful balance between our CO2 levels, which we blow off with respiration, and the pH in the blood. And when our CO2 levels begin to build up, the pH in the blood drops, becomes more acidic. And why does that happen at night? Because we don't breathe as much, and especially if you've got sleep apnea, your CO2 is really going to go up and you become really acidic. So the next question is, okay, so our blood becomes acidic at night. Why does acidic blood destroy red cells? Well, for that, we have to go into the immune system. And I will try to give you a very brief overview of our immune system, which since COVID began, we seem to all know more about our immune system. Some things we don't want to know. So the immune system is divided up into that's present at birth, which is referred to as innate, and that we acquired over time, which is because of our exposures to foreign antigens, viruses and bacteria and that type of thing. The simplest part of the innate immune system are some of the physical barriers we have. So skin prevents infection. Our mucous membranes that line many of our tracts prevent infection, and things like saliva and urine and stomach acids. All of those prevent bacteria from entering the blood, and that is what we call physical barriers. Then there are some blood-borne things that we are born with. Perhaps the most common one and simple one to understand are neutrophils. So many of you who have low blood counts have watched your neutrophil count. Neutrophils are one of the phagocytes of the body, and those phagocytes are able to engulf foreign materials. The phagocyte was discovered also in 1882, interestingly, but this was by a Moldavian zoologist. I didn't even know there was Moldavia at the time. It's now the Ukraine. And his name is Ilya Mechnikov. And he became known as the father of innate immunity for discovering phagocytes in the body. I'm only going to briefly mention acquired immune system because it's something that has become very important with COVID. Basically, there are B cells that produce antibodies, as shown there on the right, and there are T cells which can be cytotoxic. They can kill foreign materials themselves. The diagram on the left actually shows the T cells, which are in blue, attacking cancer cells. So our T cells actually are involved in preventing us from getting cancer, as well as attacking bacteria and viruses and so on. So what's the hidden component here that we're born with that's part of the blood-borne system? Is there something that complements phagocytic activity? And yes, there is, and that's what has become known as complement. Complement wasn't known as complement initially, and this German bacteriologist Hans Buchner found a protein in the blood that was capable of killing bacteria, and he called it alexin. Unfortunately, he got virtually no credit for it because this gentleman came along who is actually a very famous and influential physician from Prussia, Paul Ehrlich. He's the one that came up with the term chemotherapy that we all hear about now. He came up with the term magic bullet. He came up with the term antibody to describe something that we produce that was able to recognize an antigen target on foreign material like bacteria and attach to it. But most important for this talk, he took the word alexin that Buchner had come up with that somehow assists in killing bacteria, and he renamed it complement. Buchner got absolutely nothing for his contribution to complement, whereas both Mechnikov and Ehrlich shared the Nobel Prize in Medicine in 1908 for their discoveries in immunity. Even sadder is the fact that Buchner's brother also won the Nobel Prize in chemistry. So he wasn't well appreciated at the dinner table. Okay, already. So what's the point? Why am I talking about the complement system? It is complement that is activated by our blood becoming more acidic at night. And while it's part of our natural immune system that's targeting foreign materials, it can do bad things. Specifically, most red cells have a protective coat that prevents complement from destroying our own red cells. There are people or cells that lack that protective coating, And those that lack that coating have what's called paroxysmal nocturnal hemoglobinuria, or PNH. So this shows the what happens. The little green projections from the red cell are what's called GPI anchored proteins, and that's the protective coat that we normally have. And when complements activate it, nothing happens to the red cell when we have normal cells. The cells on the right don't have those little green projections, and they break up when complements activate it. And hemoglobin from the red cells leaks out, and free hemoglobin causes all sorts of nasty things in PNH patients. The black boxes show what happens when your hemoglobin drops. Of course, if you destroy red cells, your hemoglobin is going to drop. You become anemic, and you get dyspneic, which is short of breath. You get fatigued, that's tired. And one of the key things about PNH is that all of this complement activity can actually lead to blood clots or thrombosis. But what people often feel, aside from the symptoms of anemia, low hemoglobin, are the free hemoglobin tends to reduce the nitric oxide levels in your blood, and it causes your muscles to spasm and your blood vessels to spasm, and it causes all sorts of symptoms, especially abdominal pain, chest pain, difficulty swallowing, erectile dysfunction, as if men don't have enough reasons for that. Okay, so did I forget that I'm talking to AAMAC with all this talk about PNH? Well, this is why PNH is a topic here. This Venn diagram, if you remember your math from grade 10, shows the interesting overlap between aplastic anemia and MDS. HMDS is hypoplastic MDS, which is really difficult to separate from aplastic anemia at times, and PNH, which you can get PNH developing in MDS and aplastic anemia. Some other conditions that often have are often represented here at the AAMAC include inherited bone marrow failure syndromes and pure red cell aplasia and large granular lymphocytosis, which I'm not going to talk about today, but we're going to talk about this overlap here. So PNH cells are acquired. You're not born with them. And it affects stem cells, not just red cells. So it can affect the white cells and the platelets as well, which come from the bone marrow stem cell. Interestingly, we all have PNH cells. Very, very few. You'd have to have a very sensitive test to pick up 0.001%, but healthy people have PNH cells. In fact, 1% of healthy people will have slightly more than that, 0.02%. Of their red cells have PNH defects. But larger clones beyond that are only seen in immune-mediated bone marrow disorders like aplastic anemia, like MDS. And why is that? That's because if there's anything good about PNH cells, they are very resistant to immune attack. So you develop aplastic anemia and sometimes MDS because your immune system attacks your own bone marrow. But if you've got PNH cells, they tend to survive. So PNH can kind of expand in those conditions. And that's why you only see higher clones when you have that going on. So 50% of aplastic anemia patients will have PNH clones. Often I'd say more frequently, they're less than 1%. Some people have 1 to 10%. And when they get more than 10%, they start to look more like PNH. 15% of MDS patients can have PNH clones as well. So this PNH defect can be seen in all of the conditions that can cause bone marrow failure. So isolated classic PNH, where PNH is your problem, you're destroying the red cells and waking with Coca-Cola urine. There are about 5 cases per million per year. So that's about 25 cases are diagnosed each year in BC. And it's usually young patients, but it can be seen in all age ranges. I just saw an 85-year-old with PNH this past week. So it's early 30s is the median age. And the reason why I brought up complement is that, as I told you, PNH is a complement-mediated disease, and that is very important when you consider therapies. This is the complement system, and I have no intention of trying to bring you through this. It's a very complicated series of proteins that start with C, and they go from C1 to C9. And I'll quickly explain what happens during this activation pathway. So there's many things that can activate the three pathways that are shown at the top: classical, lectin, and alternative. In PNH, the alternative pathway is very important, and that's what a lot of the drugs have been developed for in focusing on the right-hand part of this. So what does complement do? The C3, which is in the middle, breaks up into C3A and C3B, and those two proteins are very important. C3A makes blood vessels big and leaky, and it allows the immune system cells, like neutrophils, to leak out into the tissues and attack the invaders. The C3B component, actually C3B is a neat little marker for something that's foreign. So it sticks to the foreign materials, coats it, and that allows the immune system to recognize it as foreign. So it's more of a way of marking what needs to be removed by neutrophils and other phagocytes. And if you get all the way down to the formation of this MAC, which are these four proteins that are stacked together at the bottom of the complement pathway, it's called the membrane attack complex. And what it does is it punches a hole in the foreign material. All of the contents of the material inside the membrane leak out, and the cell dies. So that's how the complement pathway allows us to get rid of foreign antigens. So treatment for PNH for many, many years was pretty rudimentary. Obviously, if you have a low hemoglobin, like anaplastic anemia and MDS, you need transfusions. Steroids or prednisone suppresses the immune system. So often people on PNH, if you give them prednisone, their hemoglobin will come up a little bit and the hemolysis will settle down a little bit, but it's not great. If you're forming blood clots, you need blood thinners or anticoagulants. And if you start to get into the area of aplastic anemia or bone marrow failure, then we often will look at either immunosuppressive therapy, and cyclosporin and ATG are the hallmarks of immunosuppressive therapy, or bone marrow transplant. So that was how we approached PNH when I first started in the 1980s and into the 1990s. But thankfully, we've come up with modern, smart treatments for PNH. And in doing so, they wanted to try and specifically inhibit complement. And to decide where to inhibit complement, they drew their plans up from looking at what happens when you're deficient in complement. Well, if you're deficient in way up on the left side, you get autoimmune disease, systemic lupus, rheumatoid arthritis, that type of thing. So they didn't really want to inhibit anything up there because you might cause an autoimmune condition in the patient while trying to suppress their PNH. On the right side, high up on the right side of the alternative pathway, if you're deficient in any of those components, you get severe infections, meningitis and pneumonia, and they really didn't want to inhibit anything up in that direction. Further down in the pathway, one of the conditions that seems to develop in patients that are deficient in those components is meningitis with something called meningococcus, which is Neisseria meningitis. They thought that they could give medications to prevent that, and therefore they focused on developing an inhibitor of C5. And this was quite an effort, and it started in the mid-1990s. And they liked C5 because most of the components of the early components of the complement system were preserved. It was common to all three pathways. They all had to go through C5. So that was what they focused on. They looked at 30,000 anti-CD5 antibodies. So that took a lot of time to screen through. And they selected 2 for human testing. One is no longer around, paxilizumab, but eculizumab was the one that ultimately came to use. It was attractive because when given intravenously, it actually would last for 11 days. So you wouldn't have to give it very often to inhibit C5. Testing began in 1999, and interestingly, it began in rheumatoid arthritis and lupus and heart disease. So that was a lot of the early studies showing it was safe, but not overly effective in those conditions. But PNH seemed like the ideal disease to use it in. It wasn't as common as the other ones, but they began to look at using it in the United Kingdom in May 2002. It ultimately led to a randomized study that was published in the New England Journal, our most important journal, in 2006. And what it showed was it was incredibly effective. On the left shows two lines. What it is showing as the LDH, which is a sign of red cell destruction. It starts out very elevated, and people who got placebo, which is the top line, it didn't change at all. People who got eculizumab, within 2 weeks, their hemolysis measure went down to normal. So it was extremely effective. And did it prevent transfusions? Well, that's what the one on the right shows, that people who got placebo, this is the percent of patients that were not needing transfusions, that went down to 0 by 14 weeks in the placebo arm. So everybody by 14 weeks in placebo arm needed transfusions, whereas half of the patients at 26 weeks getting eculizumab did not need transfusion. So it was biochemically effective, and importantly, it reduced transfusions. And not only that, it was found that it prevented thrombosis or blood clots, which is the main reason that people with PNH died in the past. So on the left, that's the pre-eculizumab era, and the point is that the median survival, average survival, was about 10 years if you had PNH, most people dying of blood clots. And with the age and gender matched controls being the top line. And you can see that after eculizumab was introduced, the two lines became overlapping. So people stopped dying of PNH after they introduced eculizumab. There is a little bit of drop off at 10 years, and that's because some people with PNH develop bone marrow failure, which is not prevented by eculizumab. Well, the company wasn't entirely satisfied with eculizumab, and they developed a long-acting C5 inhibitor, ravulizumab, and they just took eculizumab and they changed 4 amino acids. So that's 4 small parts on the eculizumab compound. And it actually promoted internal recycling of the compound. And I call it a green C5 inhibitor. So it's stayed around for a lot longer, 7 weeks. So it allowed people to get a complement inhibitor every 8 weeks instead of every 2 weeks, which is the way eculizumab is given. They compared the two in a randomized study published in 2018. The term that was used was non-inferior, and I guess for your purposes, it means they're more or less equivalent in terms of how effective they are. There were no new side effects with giving ravulizumab every 8 weeks, and what that led to was approval of both drugs. Eculizumab was approved in Canada in January 2009, so it's been around for 17 years now. Ravulizumab was approved in August of 2019, and then there was a long pause during which there's a lot of negotiations going on. It's still not available in BC through the government, or in New Brunswick. I think it's the other province. Every other province has it. Sounds like luspatercept. So we've got 2 great drugs. Problem solved? Well, not quite. It's close. But there are some problems with patients who are treated with eculizumab and ravulizumab. 25 to 50% of patients still remain anemic, low hemoglobins, and still feel fatigued. In addition, even in patients who are well controlled, infections, vaccinations, and we had to vaccinate all of the PNH patients for COVID because there was concern they would end up with serious infections, you get breakthrough hemolysis because complement is activated by infections and vaccinations and stress. If you're having an operation, you will activate complement. So you do get some breakthrough hemolysis. There's also this interesting extravascular hemolysis that can occur, and that's because you're blocking the pathway way down at the bottom, and the C3 components, the higher up on the complement pathway, tend to build up and up and up and up, and they can coat our red cells. And if red cells are coated with C3, they go to the spleen and they're destroyed. So you can have hemolysis going on in a different fashion in some patients. And then there's some patients with PNH that have, a little bit of aplastic anemia, a little bit of PNH, and their bone marrow is underactive. And even though you get rid of hemolysis, they still don't have a great hemoglobin. So the thought was we could develop a C3 inhibitor. And of course, why didn't we do that originally? The thought was that was higher up in the area where you started to run into troubles with more infections. And they didn't want to go there, but because that was what was causing extravascular hemolysis, they thought they would develop a C3 inhibitor. That's called pegcetacoplan or Empaveli. There's a neatly named trial called Pegasus that was published in 2021, in which patients who were on eculizumab who had persistent anemia. So this isn't people who had great hemoglobins, normal hemoglobins on eculizumab. It was people who had lower hemoglobins. Average was about 87, if people know what that means. They were randomized to either continue on eculizumab or go to pegcetacoplan. Initially, they were given both, and then they split off into taking either eculizumab or pegcetacoplan. And that's the curve shows, the lines show the hemoglobin levels. And initially, people who got both, their hemoglobin level went up from that 87 range to a normal range, around 120. And people who stayed on pegcetacoplan, it stayed up there. People who went back to eculizumab, it dropped back down. And people who were on PEG had obviously less fatigue because their hemoglobin was better. Headache is something you're going to see in almost all of these complement inhibitors because it's caused by improvement in nitric oxide levels. So everybody who's responding to a complement inhibitor will get headaches. So you see that reported as a common side effect as well. PEG had some new side effects. Obviously, injection site, you're given eculizumab intravenously, you don't get injection site inflammation, but about a third do with PEG. And it does cause diarrhea in about a quarter of patients. But interestingly, even though we started looking at these complement inhibitors that were higher up and higher up in complement pathway and more of an infection concern, there were no difference in infections. So it was the Pegasus trial that led to pegcetacoplan being approved in December of 2022. It is available in British Columbia and I think in all provinces. So we're at the finish line. Again, there have been some other issues that are not quite dealt with yet. You can still see breakthrough hemolysis. It seems that when you block the pathway high up, when you do see breakthrough hemolysis, it can be quite dramatic. So you can see breakthrough hemolysis with pegcetacoplan, again, under immunization stress or infection stress or whatever. All three drugs that I've talked about are inconvenient in that you either have to have an intravenous infusion every 2 weeks or a subcutaneous infusion twice weekly is typically the way PEG is given. You have to have heightened infection prevention measures, so vaccinations. We usually recommend penicillin prophylaxis indefinitely in patients who are on these complement inhibitors. Although, again, we have not, that seems to be effective in preventing any infections that are serious. And expense, and that's been a problem with all of these drugs. It's it's a little bit variable, but somewhere between $400,000 to $500,000 a year per patient. But because of the amount of money involved per patient, it has stimulated a lot of interest from pharmaceutical companies to develop drugs in this area. And when they went beyond pegcetacoplan, they even went higher in the alternative pathway, looking at two factors that don't even have a C before them, factor B and factor D, which complement, so to speak. And the development of new drugs focused on oral forms of this. The first oral inhibitor was danicopan. It inhibits factor D. It's a pill that's given 3 times a day. It was tried in 10 patients with PNH that had never had any treatment, and all responded well with a reduction in hemolysis, i.e. their LDH, and an improvement in their hemoglobin. It led to a trial in which patients who were on eculizumab or ravulizumab and had a lower hemoglobin were given danicopan in addition to those drugs for 3 months, and all of them improved their hemoglobin and had less symptoms as a result. And again, headaches were seen because it started to work even better. Nitric oxide levels dropped. There were some mild liver abnormalities, which were not something that caused symptoms. So it looked like danicopan as an add-on to these 2 drugs was effective. So it was approved in July of 2024 in Canada. In March of 2024, in the New England Journal, there was a publication on another inhibitor. This one was an oral factor B inhibitor, and it only has to be given twice a day. But more importantly, it was developed as a standalone drug. It wasn't to be added to one of the existing drugs in PNH. It was going to be used as an oral drug alone. And there were 2 separate trials, one of which looked at new PNH patients that had never been treated with anything, and those that had been on one of the approved C5 inhibitors, eculizumab and ravulizumab, but had a lowish hemoglobin. And I guess what it showed was that much like danicopan, patients had an excellent response in both studies, but amazingly, 2/3 of the iptacopan patients developed a hemoglobin over 120. None of the patients who stayed on eculizumab or ravulizumab had anything near that. And it did so rapidly. And I've used this drug a few times, and usually the hemoglobin is normal within 2 weeks. You put people that have had no good hemoglobin levels for years on iptacopan, and suddenly within 2 weeks, they're up to normal. And again, not surprisingly, it caused headaches because the nitric oxide levels suddenly rebound. As an oral drug, it can cause nausea and diarrhea. I've not seen a lot of that in the patients that I've treated, but any oral drug can do that. So it was approved in January of 2025. So now 5 drugs in PNH. So that's fantastic. Now we've got oral complement inhibitors. They're highly effective, and they have virtually no serious or significant new side effects. But first of all, danicopan is marketed as an add-on to eculizumab and ravulizumab in patients who are not optimally responding to those drugs. That leads to a markup of somewhere around $100,000 a year per patient. So that's in addition to the $400,000 to $500,000 that they're already paying for Ecu and Ravu. You can't stop Ecu and Ravu. It's not marketed as a standalone drug. Canada's Drug Agency felt that it had good results and it should be reimbursed with certain conditions. And that then goes to negotiations with the Pan-Canadian Pharmaceutical Alliance. And they were concluded without an agreement. Reading between the lines, it was too expensive. They didn't feel it should be something that should replace, say, switching to pegcetacoplan. That would probably also lead to a very good response in patients with extravascular hemolysis and not nearly as expensive. So I suspect that was what the whole holdup was. Iptacopan is a standalone drug, so you don't have to worry about it being added to something else, but it suffered a similar fate, getting a non-agreement with the Pan-Canadian Pharmaceutical Alliance, although that has recently been revived because it appears that iptacopan is going to be put forward as a treatment for a kidney disease, and that may lead to it coming back to the Pan-Canadian Alliance for review again. So right now, these two great oral drugs, not available. And I'm not done because there is a sixth drug now. I can't tell you exactly why this came about, although this obviously the company had been developing it for a while, but it's a C5 inhibitor that, unlike Ecu and Ravu, is given subcutaneously like PEG, and it's given every 4 weeks. So it's a long-acting subcutaneous injection. Is that better than IV? Well, it appears so. Trials that were called the Commodore trial compared this drug crovalimab to the long-standing drug for PNH, eculizumab, and they found once again that it was non-inferior, in other words, equivalent. And patients on this study who actually ended up taking both at one time or the other, 84% of them said they preferred the subcutaneous crovalimab over the IV injections. Maybe because it was less frequent, maybe because they just didn't like IV, and maybe because they had to go to a clinic to get IV and they could do sub-Q at home. So don't know exactly the reasons, but it appears that this drug is favored by patients. It has one unique side effect if you've been on Ecu, and that is that because they, again, the immunology is kind of tricky, but they target the same C5, the same complement component, but they target different parts of that C5. And because of that, you can get a hypersensitivity reaction, which is usually mild. It happens in 15% of cases. So people may get a bit of a skin rash, sometimes just at the injection site, but can be diffuse. You can get fevers, joint pain, and swollen glands, and even involvement of the lungs or the kidneys. But that is extremely rare. So it's probably better to start crovalimab directly and not switch from Ecu to Crova, but you can do it. Right now, I believe that there is a thought that crovalimab may be available here in BC as a frontline agent. You can choose between Ecu or crovalimab, and how that's selected, I'm not even sure how it's going to go. It's going to be patient preference and so on, but that has not been finalized yet. So now we have the sixth drug. Crovalimab was improved in June 2025 by Health Canada. So now the complement inhibitor landscape. I actually looked at my my USB key and saw that I gave a talk in 2023 on PNH. And while some of these drugs were under development, the only drugs that were approved were Ecu, Ravu, and PEG. Now we have all 6 approved. They're not all available, but I suspect they will become available. I'm just not sure when. So this is kind of the PNH treatment landscape. I'd say confused is probably not as appropriate now as uncertain exactly where we're going with this. What's going to be front line? What's going to be second line? Are the oral drugs going to become more available? And there's a lot of dollars and negotiations involved in this. And fortunately, I just like to offer patience and I don't have to worry about the financial end of things. And I'm happy to answer questions.
How does a patient know that this is a problem for them? Is there a blood test to do this? If there is a blood test, is it something that we have life labs in BC recognize what you put on requisition to find out, and then based on that, then is that where we go towards the treatments? we know that we have a problem with PNH unless we get a blood test? And how can we get a blood test?
Well, for layperson, you hit the nail directly on that one. PNH is renowned for being something that is misdiagnosed or undiagnosed for years because not everybody has the Coca-Cola urine. And even if you did, often what is done by general practitioners is, oh, they've got a urine infection. And they give them antibiotics. They might do a urine test, and the urine test might come back negative or occasionally positive, but they think it's a urine infection. And because PNH goes through these bursts of where complements activate it, and you have a drop in your hemoglobin, blood and urine, or black urine, and then it goes away. And it can go away for weeks or months or even years. And then it comes back when you have another, oh, you're given an immunization, and suddenly your hemoglobin plummets and you get black urine again. And GPs, I understand it's a rare condition, very rare condition. How do you detect it? Yeah, I don't know if I've seen many GPs pick it up, but they often will send people on to a specialist for further investigations, and often they don't pick it up unless they're a hematologist, and there aren't a lot in the province. There's more now, but not a lot. How do you pick it up? There is a straightforward test. It can be ordered anywhere. It's called flow cytometry for PNH. And flow cytometry, basically, what they do is they just like a blood count where they run the blood through a machine. They run the blood through a machine that will look for those little green sticks that come out of the red cells, and they'll find they're absent. And that is how they diagnose PNH. It's quite easy to do. It can be done anywhere in the province, but they have to know how to order it. As I say, it's literally a CBC tube, a single blood tube, and it's sent down to an immunology lab. There's probably about 5 or 6 labs in the BC that can do it. Victoria can do it, we can do it, Kelowna can do it, Prince George can do it. But if they can't do it, they'll send it down to a lab that can. It's really easy to do. How do you pick it up? Well, I think what might be the clue is lots of patients have anemia. They'll come in with low hemoglobins, and GPs deal with that all the time. What would be unusual about it, if they're not having black urine, is that the LDH will be sky high. That's the hemolysis enzyme. And you know what? LDH used to be part of what we call liver function tests. So if you ordered liver function tests, LDH would be done. Somewhere through the years, it got pulled out so that you actually have to specifically order LDH. And I can't remember the last time I saw a GP order an LDH. It's very easy to do. They can add it to normal chemistry, but often they don't. And when we moved to our new computer system at BGH, where LDH used to be part of the liver function panel, it was pulled out so that if you don't order LDH at Vancouver General, you specifically order it, you will not get it, and you will miss it completely. And virtually nobody orders LDH outside of hematologists. So it's very frustrating. It's easy to get a clue something is unusual, but it's rare that people will actually do the necessary test. Hence, it's often missed for years. I think what perhaps leads people to diagnosis a little sooner is people who develop blood clots. Now, that's a little bit different than presenting with anemia, which is extremely common. Whereas blood clots, which can occur in really odd spots, like in the abdomen as opposed to in the leg. Like people get blood clots in the legs all the time, but the ones in the abdomen are very rare, or around the brain, very rare. And those often lead to the diagnosis of PNH much sooner. But usually it's anemia, and it's just going to keep being missed. I'm not sure I've gone out, and Leah can probably attest to this. I've gone out and talked around the province about PNH. I've been up to Prince George, I've been to the interior, I've been to the Kootenays, I've been to Victoria, down the Fraser Valley. I've given lots of talks on bone marrow failure and PNH. And aside from hematologists, I don't think I've gotten many people who've recognized PNH.
Follow-up. So monitoring PNH in patients with other bone marrow disorders like the aplastic or anything like that?
Yeah, so usually in MDS patients and aplastic patients, I will do a PNH flow cytometry at the time I diagnose them or the first time I see them. And if they've got a significant clone, like if they've got a measurable clone, I'll do it every 6 months to a year because it can increase over time. It can decrease over time. Most commonly, it doesn't change over time. It's just very stable. But we have seen patients who I can recall an MDS patient, just thinking about your husband there. I can recall an MDS patient who had straightforward MDS. And then about 2 years later, he presented with black urine, and he had a PNH clone that was very, very high. So that can happen. So we do like to monitor it at least yearly to make sure it's not changing. If it hasn't changed after 2 or 3 years, it probably isn't going to change. But that's just a personal experience. I think the recommendation is people who've got clones, you should do it once a year. Simple blood test.
PNH more common in men?
I don't think so. I think it's probably equal. MDS is more common in men. In fact, it seems that I just recently looked at all of the bone marrow failure patients over the last 10 years, and the male to female ratio is 1.5 to 1. So you'd think that, but I think that's largely because MDS skews it. Just MDS is more common in men. I think aplastic anemia is the same in men and women, and PNH as well.
Yeah,
Yeah.
I'm Yuri Sulka. My mother was diagnosed with aplastic anemia, blood PNH. So I'm wondering at what PNH clone size do you recommend to start treatment? There is like a DEF score plus like clinical symptoms. So that patient start a treatment, or what happened when the clone size decrease? You stop the treatment?
Yeah, so in people with PNH, so let's just leave out people who have a little bit of aplastic anemia or people with MDS. With people with PNH, we have, in order to get approval for the drug from the government, we have to repeat the PNH clone every year. So they want it documented. And I've had one patient in my last 15 years of using eculizumab whose PNH clone went from 90% down to less than 10%, and I stopped the drug, and it's still going down. So if it goes to less than 10%, then I usually recommend stopping the drug, and it's only happened to me once. So it can go down and disappear. Yeah. So when do you start the drug? I think it's mostly related to the hemoglobin level. And you have to reach a certain hemoglobin level that you need transfusions. The government will not pay for it if you've got PNH, and we have a few of these whose bone marrow is so healthy that, that they're hemolyzing. There's a lot of red cells being destroyed, but they're producing so many red cells to make up for it. They don't need a transfusion. Other people, they just hemolyze so much, they need transfusions. Those are the ones the government will pay for. And you have to have a certain LDH level, which is usually pretty easy to reach. So there has to be a certain degree of hemolysis. It has to be 1.5 times the upper normal, which is very easy to reach. It's mostly red cell transfusions. You need red cell transfusions to be a requirement to get the drug.
The effort underway to rename PNH?
What's interesting, you'd think so, because only about a quarter of patients actually have PNH, paroxysmal nocturnal hemoglobinuria, where they get black urine periodically, paroxysmally. So in some way, it's a bit of a misnomer. But, these names tend to stick around. It's really hard to change it. Yes, Mary.
So the screen that showed the overlaps with
Yeah.
MDS, that was really interesting. Especially, I think a lot of the problems for, you know, whether it's the medical side or patient side, is chasing the needle in the haystack and diagnosing, right? And seeing some things seem to mimic other things. So in your experience, is it possible that even though somebody has had a diagnosis with MDS through a bone marrow biopsy showing the mutation, that some of the side effects, be it low red blood cell count and lower platelets, PNH can mimic? Like you showed the overlap without the Coca-Cola urine? Is it worth an investigation? Even though they.
As I say, every MDS patient I see, even if it's a well-established diagnosis by some other physician, I do the flow cytometry for PNH, so I know what's there. Because there can be some overlap, and as we've talked about, it can increase over time. So it's worthwhile at least documenting that. I've had patients sent to me with aplastic anemia and they've had PNH. I've had patients sent to me with MDS and they've had PNH. I've had patients sent to me with MDS that actually have aplastic anemia. So there is an overlap in some patients with, you know, you can't quite tell whether it's MDS or aplastic anemia. They will respond well to aplastic anemia treatments. I've got half a dozen of those that I've treated for 10 years and they're still doing well. So the treat, not just the diseases, but the treatments can overlap.
So the drugs you said were not, the negotiations didn't work out with the Pan-Canadian. Are they still available to patients like drug company passion program?
I don't think they're available compassionately. I know that I had a few patients who are on compassionate iptacopan, but after the last negotiations didn't lead to agreement / fell through, they stopped the compassionate program. It's still available if you've got third-party coverage. So I've got one patient who started it who had very good third-party coverage, even though it was no longer compassionately available. Danicopan, I think is similar, that you probably need third-party coverage. So it is available, it's marketed. It's not been pulled from the market. It just isn't funded by the provinces because they haven't been able to reach an agreement with PCPA.
I just wonder if all these medicine, do they exist only in Canada? Or, I mean, is there, you said that you know their negotiation didn't go well, and you know, but for example, a patient, they find out that medicine in India or another country with chips that are not using that same tech, or you know, because you can compare the, you know, the journals, paper, you know, the procedure that's that. Is it possible for a patient to import the medicine from outside Canada?
Yeah, I don't know the answer to importing. I suspect not, unless it's hidden in a false bottom of a suitcase.
Yeah,
because then you have to get somebody to inject it, right?
Importing, oh no.
Yeah, but I can tell you in terms of getting it in other countries, the US, these drugs are widely available, but it cost you a fortune. Like all of them are available in the US. They're usually approved by the US FDA before they ever get approved by Health Canada, whose regulatory system's much slower and it grinds along at a very slow pace. I know that we recently had a patient from India where we talked about its availability in India, and I think they have so many generics in India that it's a lot cheaper. How available it is, it's a lot cheaper, but certainly the social structure is much more complicated in India. I don't want to get too far into that, but I think there are, you know, if you had money in India, you could get it a lot, very easy. And yet it's trickier here.
Another question, it's just my own knowledge, but you mentioned about the percentage of clone.
Yeah.
The PNH.
Yep.
So what you would say, okay, this percentage of clone, it's okay, or you can deal with it. Like you said, 10%, 20%, like a threshold.
So in my practice, patients who have clones up to 10% and are sort of aplastic, I just consider aplastic anemia. If they've got an aplastic bone marrow and they've got more than 10%, I usually call that an aplastic anemia PNH overlap. Usually they will not start hemolyzing to the point of getting severely anemic until their clone gets to around 50%. So those are the patients that start to get into, oh, they need one of these drugs when they're up at 50%. Yeah, but occasionally there'll be patients that are a little more complicated who have slightly lower clones. But people less than 10%, I've never treated anybody with one of these drugs if they've been less than 10%.
First time I've seen all this medicine, and like my wife said, we kind of dealing with a situation per month aplastic anemia, and she's been treated in Lima.
Okay.
And she's been treated with L-Trombopag. I don't know that the name of that. But
L-Trombopag is used in aplastic anemia. Although it's not funded in BC for aplastic anemia, Apotek's drug company has been very generous in providing it for everybody with aplastic anemia so far. And we just have to ask them. They give it a month at a time. So yeah, L-Trombopag it's not something that would necessarily be useful in PNH, but it does work in aplastic anemia and has been used in MDS. People with low platelet counts, it does help.
But similar to this, let's say, state-of-the-art treatment for PNH, L-Trombopag is kind of the same for aplastic anemia, or do you see that Canada, there are some much better treatments than using only L-Trombopag?
Well, the best treatment if you're young enough is bone marrow transplant, and we recommend it in people up to age 40 with aplastic anemia. But we feel the state of the art in aplastic anemia is to treat with cyclosporin, ATG, and L-Trombopag, the three drugs together. The L-Trombopag is continued for 1 year, and the cyclosporin is continued for 2 years. So that's our standard treatment for aplastic anemia that's not getting a transplant. And so far we've been able to do that by getting L-Trombopag from Apotek. We'd like to get it from the government. We wish it was part of our standard protocol, and hopefully we'll get there. I've got somebody with PNH from Lima, Peru, actually. She's the one who actually came off. She was the one whose clone disappeared, and she was able to come off of treatment. So
that patient in Lima directly, she's here,
she's here. Yeah, she's here. She came here immigrated here.
Thank you so much,
Thank you.
Dr. Neville. Thanks for speaking. So I'm very pleased to introduce our second speaker for today, Dr. Heather Leitch, who'll discuss the management of blood transfusion and iron overload in MDS. Dr. Leitch is a hematologist at St. Paul's Hospital in Vancouver and clinical professor in the Department of Medicine at the University of British Columbia. Dr. Leitch's clinical and research interests include transfusional iron overload in acquired anemias, such as the myelodysplastic syndromes, and a longstanding interest in lymphoproliferative and other blood disorders in the setting of HIV infection. She's Director of Hematology Oncology Research at St. Paul's Hospital, a reviewer of scientific papers for multiple medical journals, and a member of the UBC Department of Medicine Research Advisory Committee. And I believe she's also a member of the AAMAC Medical Advisory Committee, has been for a very long time. So thank you for joining us.
Thanks very much, Fiona. So Dr. Neville's a bit of a hard act to follow, but I'll do my best. So Yeah, so I'm going to talk about management of blood transfusions and iron overload, and mostly the latter, because as you know, we don't really have enough medications to manage the former. So these are my disclosures. So MDS, as you know, is a group of clonal bone marrow disorders characterized by ineffective hematopoiesis and the potential for progressing to acute myeloid leukemia. Overall survival and AML progression are predicted by the IPSS and newer scores, most recently the IPSS molecular. This is actually a slide I kind of borrowed from CLL, but MDS does present this way as well. So you see this peak of presentation sort of in the mid 70s, and then it falls off. Does it truly fall off? Probably not. Probably people in their mid 80s and early 90s, many of them anyways, have comorbidities that make people reluctant to do invasive investigations on them. But I can tell you that I've had more than a couple of people in their early 90s who I've said, sure, I'll do a bone marrow biopsy on you. You're in better shape than I am. So this is a bit old because it does discuss the IPSS. I'm not sure. Can you guys see my arrow yeah, okay, perfect. So this is the age-related incidence of the general Canadian population. So if you make it to 65 years, you have another 19 years left. If you make it to 75 years, you have another 12 years left. This is IPSS low, intermediate 1, intermediate 2, and high risk. And so in red, low risk, if you make it to 60 years, you only have another 4 years left. If you make it to 70 years, less than that. And you can see the high risk category, the survival is very limited. So we need to do better. These are the median overall survivals in the IPSS-M and IPSS-R. So IPSS-M, very low, moderate, high, and very high. So you can see that it looks a little less bleak, at least in the lower risk groups. IPSS-R, sort of all comers, and IPSS-R age adjusted for age over 70. And again, it does look better, although the most sort of accurate score that we have right now is the IPSS molecular. Transfusion dependence, 40% of low-risk patients in the IPSS and 80% of high-risk patients. Specific information on how many patients are transfusion dependent in the IPSS-R and IPSS-M by risk group is not available as far as I know. So when we make treatment decisions in MDS, we base this on, disease-related factors such as number of cytopenias, percentage of blasts in the marrow, and the chromosome analysis, which feed into the risk scores, but also a big one in Canada, particularly in many locations, is distance from the treatment center as well as age and comorbidities. So one of the things that's a little bit difficult to get your head around in MDS is that classification and prognostic systems keep changing. So we started off in the 1980s with the FAB classification, French, American, British, by Dr. Bennett and colleagues. Dr. Bennett is now in his mid-90s. He's one of those fabulous 90-year-olds who comes to the meetings still and says brilliant things. And then we went through a variety of different scores and different updated classifications. Most recently, the classifications are the World Health Organization 2022 and the International Consensus Criteria 2022 and the IPSS-M prognostic score. So in the future, probably we'll be looking at things like, so the IPSS-M looks at somatic mutations, but we'll look at things like epigenetic changes, so sort of on top of the nucleic acids rather than within the nucleic acids. And there are a couple of machine learning-based algorithms as well. But one of the things so first I'm going to show you how the classification systems, 3 of them relate to each other. So you can see it's complicated, and that's why we have dedicated hematopathologists. One of the things that we participate in at St. Paul's is the MDS CAN, or the Canadian National MDS Patient Registry. And this is based at Sunnybrook in Toronto. Dr. Rena Buckstein has been a driving force. And so it was started in 2007, went national in 2012. And patients, many of you probably participate in this, but patients fill out questionnaires every 6 months on quality of life, and every year undergo small tests of physical function. The 4-meter walk test, how fast can you stand and sit 10 times, and hand grip strength. And actually they have a manuscript just being submitted that shows that hand grip strength is related to overall survival. So we also prospectively collect MDS related data, but also the different frailty scores. So this is an early publication from the MDS CAN registry. So incorporating patient-related factors, so frailty and what's called the Charlson Comorbidity Index. Rena did weighting and then came up with this new prognostic score, and you can see the survival curves vary widely. So of course, we all know that frail patients are going to do worse, but this is the first thing that starts to quantify it. And this is still the only score of all that list that I showed you that really takes into account patient-related factors. So one of the things Rena is working on now is incorporating these frailty scores into the IPSS molecular to come up with a super prognostic system. Now, in terms of treatments for MDS, this is something I borrowed from one of my international colleagues, and shows all the cellular pathways that were being targeted in clinical trials for MDS in 2019. This is in 2022, all the things that haven't worked out. So that's a little bit discouraging. And it could turn out that, we really need to get more specific and target specific molecular pathways, but we haven't gotten there yet. So available treatments for MDS, I've got available in quotations because we don't always have access. So for lower risk ESA, erythropoiesis stimulating agents like erythropoietin, darbepoetin. I want to point out this has actually never been funded in this province. We access EPO on a patient support program, and I do worry about what happens when that patient support program comes to an end, which unfortunately hasn't yet. So lenalidomide is for patients with del(5q) MDS, which is around 5 or 10% of patients, so applies to a minority. Luspatercept has been shown to be effective in MDS. It's an erythroid maturation agent. Unfortunately, it's not funded in BC. BC is the only province in Canada that doesn't fund luspatercept, which is perplexing and very annoying, and I'll come back to that. Imetelstat is a telomerase inhibitor. So the telomeres are the small, bits of nucleic acid on the end of chromosomes. And what happens as cells age is they shorten. So MDS cells already have shortened telomeres, and imetelstat makes them even shorter so that the MDS cells die. And so this is a very interesting treatment because it actually has been shown to decrease variant allele frequency, and that's VAF, how we quantitate how much of any particular specific mutation is present in any patient. This is not yet available in Canada. It was made, it is still in the US, made by a company called Gilead. I contact the Gilead Canada people. They say talk to Gilead US. I go stand in their booth at the American Society of Hematology, and they say talk to the Canadians. So that's a bit disappointing. But I did have a conversation recently with a company called Medicine, which is based in Israel, and they are considering bringing this medication to Canada. So I did my best to encourage them. So 3 iron chelators, deferoxarox, deferoxamine, deferoprone, as you'll see, there are potential problems with all of them. We did have a clinical trial of pyruvate kinase activators. So this is supposed to, pyruvate kinase sort of protects the cell membrane and is supposed to stabilize the red blood cells and lengthen their lifespan. It works quite well in hereditary anemia such as thalassemia, but unfortunately did not work well in MDS. So higher risk, we have azacitidine, which is a hypomethylating agent. We also have decitabine cedazuridine, another HMA. And these are some of the things that recently haven't worked out. Magrolimab, sabatolimab, venetoclax, all added to azacitidine, pembrolizumab, anacetinib. There's also epronatapop, which is a TP53 activator, TP53 being a very bad mutation in MDS. However, I recently read some preclinical data that suggested that arsenic trioxide, which we actually use in a subtype of acute myeloid leukemia, also reactivates TP53. So that would be very interesting if that worked out in MDS. So ESA, APO, and DARBO, as I said, patient support program, reasonable response rate. Response does vary by baseline erythropoietin level in the body and by other factors. Median response duration is only 1 to 2 years. Of course, there's a range around that. Some patients don't respond at all, and some patients have a very long response. I have patients who've been on it for several years. So patients with an erythroid response, iron will decrease over time as iron is incorporated into newly formed red blood cells. And for patients whose hemoglobin can tolerate it, I sometimes hasten reduction of iron overload by phlebotomy so that we start at a minimal level when patients become transfusion dependent. Lenalidomide, an immunomodulatory agent, as I said, for del5Q MDS, it gives erythroid response in 66% of del5Q MDS. Response duration is 1 to 2 years, and same comments on iron as for ESA. Luspatercept, erythroid maturation agent, or EMA, very good erythroid response rate in ring sideroblast or SF3B1 mutated MDS, reasonable response rate in non-RS SF3B1. Patients with an erythroid response have been shown to have superior overall survival to those that do not. As I said, it's currently not funded in BC. One of the patients that I share with another hematologist is actually championing what do you call it? Where everyone signs. Petition. Thank you. I just got back late last night from Toronto and I'm flying to London today. I do not recommend it. It scrambles your brain. Sponsoring a petition. So I'm sure that she and her sister would be happy to talk to you about that. Imetelstat, telomerase inhibitor, I kind of said this already, gives responses, decreases VAF. So this is disease modifying because it is decreasing the level of the somatic mutations, in other words, the number of MDS cells. Whether that's the case with the other medications that I showed you is unclear. It hasn't been demonstrated at this point. Currently not available in Canada, and I had the meeting. So decitabine cedazuridine is a hypomethylating agent. It's given orally. The cedazuridine stops the decitabine from being broken down in the GI tract. So it does remove methyl groups from nucleic acids, and so it changes gene expression. Methyl groups silence gene expression. Which genes these are is not really clear. It is indicated in IPSS intermediate 1 MDS, so some lower risk patients, although I do have to say that I'm reluctant to use it in lower risk patients, as once people are refractory to hypomethylating agents, what are we going to use when they progress to higher risk MDS or AML? So the other thing that I will say is that data from MD Anderson indicated that the bulk of IPSS in 1 patients on DEXY were actually upstaged in the IPSSR and the IPSSM, the newer scores. So I think that, the trial that showed that, yes, it works in intermediate 1 IPSS is, well, that's nice, but they weren't really lower risk patients. We do have some clinical trials in lower risk MDS in first line, a phase 3 randomized study to compare luspatercept versus EPO 2-to-1 for treatment of anemia in lower risk MDS. It did just close to enrollment, so no longer available. In second line, we also have a trial that randomizes patients who are so the first one was for transfusion independent patients with a lower hemoglobin. The second one is for transfusion dependent patients who have no longer responded to EPO or DARBO and are randomized 2-to-1 to elritercept, which is a second generation luspatercept-like agent versus placebo. So the downside of this is that some patients get randomized to placebo. The upside is at least we get access for some of our patients to access one of these agents. I do have to say that our infusion unit is having some capacity issues, so we've kind of paused enrollment on this study for the moment, but are looking at ways to get it up and running again. Future clinical trials in lower risk. I do have a first line trial coming up, randomizing patients between elritercept and EPO, similar to the luspatercept trial. And the thing that I like about this is that, you know, even if you're randomized to EPO, it's still a good treatment. Whereas if you're randomized to elritercept, it gives you another treatment option as long as we don't have funding for luspatercept in BC. If they are going to come through with luspatercept tomorrow, then I will drop this trial. So we do also have a new iron chelator coming. And so it is a phase 2 study of this iron chelator in MDS. It's supposed to have less toxicity to the kidneys than does deferasirox, which is the usual iron chelator we use. And in higher risk, my colleague Wendy Davis has azacitidine plus sonrotoclax, which is a second generation BCL2 inhibitor. The trial of AZA plus venetoclax was negative, but there was a suggestion that in certain subgroups of higher risk MDS, they might actually benefit. So in this trial, they're going to be looking more closely at some of those subgroups and doing the statistics so they can actually show if they're a benefit. And also, this is supposed to be a more powerful agent than venetoclax. So with that, I'm going to turn to management of iron overload, unless people want to pop in with questions. No? Yes.
Those elritercept and that EPO, those trials. These trials are for patients who are taking blood transfusions.
So, so the first line elritercept trial that's coming up, as well as the first line luspatercept trial, were for transfusion independent patients who were anemic. The second line, the elritercept versus placebo, is for transfusion dependent patients. Yeah. So iron comes with transfusions, and I've sort of based this around a session I did at the American Society of Hematology in December 2025. I was actually planning to not go to the US again until they come to their senses, but this is not something you turn down. The session was called Biology-Based Management of Iron Toxicity and Iron Overload in Hematology Clinical Practice. And so the session chair is a hematologist called Thomas Coates, who is a hemoglobinopathies guy based out of LA. Love the title of the session, which is why I read it to you. So there are multiple analyses suggesting iron chelation therapy is at least associated with improved overall survival in MDS. And this is an early study that we did in 2006. And you can see that the survival of the patients receiving iron chelation was better than that of those that did not. And this was a new concept in MDS and got a lot more attention than I ever dreamed that it would, and sort of laid out a whole career path for me. These are some of the updated studies that we've done. And so the first study and many of the updated studies were actually done as summer student research projects. So the students, I had 2 students that summer, and they sat with the dusty old charts and dug through them, and this is what resulted. Okay, so the approach I took was who, when, why, and how. So which MDS patients are appropriate for iron overload management, appropriate time to intervene, evidence for a clinical benefit of iron overload management, and practical recommendations about how to offload iron. So the clinical benefits of iron overload management in hereditary anemias have long been known to be quite dramatic. It includes organ preservation and dramatically improved overall survival, and that's widely accepted. So in the thalassemia patients in the era of deferoxamine, which is infusionable, and so people weren't compliant with it, it was shown that if they're compliant more than 300 days per year with their infusions, it actually improves their median survival from the teens to normal. So there's not many interventions in medicine that we have that causes that kind of a dramatic effect. MDS patients, though, are older and may have comorbidities. Treatments to extend survival, as we just saw, are limited. And so the clinical benefits of iron overload management were more challenging to demonstrate and, more vigorously debated. But we do have current prognostic systems that identify MDS patients with reasonable life expectancy who may benefit from iron overload management. And half of MDS patients become transfusion dependent and develop iron overload. And there are lots of preclinical and many now clinical data indicating an adverse impact of iron overload on cellular and clinical endpoints and clinical benefit to iron overload management. So I'll go through much of this and may actually go a few minutes over, we'll see. Okay, median age at MDS diagnosis is 76 years in Canada. Survival ranges widely. Time from MDS diagnosis to red cell transfusion dependent in lower risk patients is 6 months in our data set in Toronto. And so the hemoglobin in transfused red cells contains considerable iron, which the body has no mechanism to excrete. So iron can be offloaded by restoring effective erythropoiesis using MDS-directed treatments, which of course we would prefer to do, but there aren't enough of them, or by iron chelation therapy. And so these are medications that bind iron, render it non-toxic, and in a form that's excretable from the body. So I'll review iron overload development, describe iron overload measures, define severity, identify mechanisms of toxicity, patients appropriate for management, when to address it, define clinical goals and numeric targets, and recommend how to offload iron, as well as identifying data gaps and future tools to minimize iron overload toxicity. So this is 20 years ago now that Dr. Malcavati and colleagues in Pavia, Italy showed that their transfusion-dependent MDS patients had inferior survival to those that were not transfused 21 years ago. Actually, it was 2005. They also showed a stepwise decrease in survival. So the top curve is patients needing no units per 4 weeks, then 1, 2, 3, and 4 units. You can see that decrease in survival. And this is from the European Leukemia Net MDS patient registry. So transfusion independent patients have the best survival. Transfusion dependent patients have the worst survival. And they called these high transfusion burden, and these are low transfusion burden. These are patients that received less than 1 unit per month, but you can see there's still a decreased survival compared to transfusion independent patients. So transfused iron accumulates in organs and leads to organ dysfunction. So we worry about the liver, the heart, the bone marrow, and the endocrine organs, as well as the pancreas, which I'll come to. And so the usual way that iron is transported in the blood is by transferrin, which is a protein that binds iron and delivers it to cells. But when transferrin becomes saturated, we get the occurrence of non-transferrin bound iron, which can deposit directly into the tissues and organs. But also a subset of NTBI is redox active. So if you remember from high school, the ability of iron to transfer electrons, and so that causes damaging oxidative species, which I'll talk about in a little bit. We also, in certain subtypes of MDS, have increased iron absorption through the GI tract through a pathway that I won't belabor. So, iron is important. It is incorporated into enzymes, into iron sulfur clusters, which are incorporated into enzymes, into myoglobin and into hemoglobin. And it's also important in the mitochondria, which are the powerhouses of the cell. It is stored as ferritin or hemosiderin. But as I said, we worry at high transferrin saturation. So it's initializing. Why is it initializing? Okay, so at a transferrin saturation over 80%, we see redox active iron, in this case, labile plasma iron. And so this is important because we can measure things like labile plasma iron, LPI, non-transferrin bound iron, NTBI, reactive oxygen species, ROS, through a flow cytometry-based assay, but that's not used in clinical laboratories. One thing that we measure all the time is the transferrin saturation. So I do worry about my patients less once their transferrin saturation is less than 80%, even if their ferritin is high. So this is kind of already what I said. NTBI go into the tissues and organs, including the bone marrow. But because of the ability of iron to transfer electrons, it goes through this stuff and causes these reactive oxygen species, which are not all created equally. So, for example, hydrogen peroxide is weakly oxidizing, but it can permeate through cell membranes. And so it can have its actions at a distance and it's long lasting. Some of the others are strongly acting, cannot go through cell membranes, and are short acting, or short lived, I should say. So there's been multiple preclinical studies showing that reactive oxygen species, a redox active form of iron, damage lipids, proteins, and nucleic acids. What are our cells made of? They're made of lipids, proteins, and nucleic acids. And I'm going to show you a little movie that sort of belabors that point in a minute. So that's already what I said. So we can also measure long-lasting results of oxidative damage. For example, oxidative DNA products such as 8-OHDG, which are damaging to nuclear and mitochondrial DNA, and also lipid peroxidation products such as malonaldehyde, which are long-lived and can go on to oxidize other macromolecules. And so now we are going to show you the little film which has scary music, so I like it when we have the sound.
Hydroxyl radicals are unstable and will indiscriminately attack DNA, proteins, and lipids in the vicinity. DNA is highly sensitive to attacks from free radicals, resulting in structural changes, strand breaks, and other modifications that can cause mutations or cytotoxicity. Protein reactions can result in cross-linking and structural distortions, profoundly affecting the function of enzymes, channels, and receptors. Lipids are another prime target, in particular polyunsaturated fatty acids that comprise plasma membranes. Lipid peroxidation alters the fluidity and structure of membranes, leading to dysfunction and lysis of cells or organelles. Oxidative damage can accumulate in mitochondria, greatly affecting the ability of cells to fulfill their energy demands. Mitochondrial DNA is particularly susceptible as it lacks histones for protection and effective DNA repair mechanisms. Impaired mitochondrial enzymes and membranes result in functional abnormalities, ineffective energy production, and organelle lysis. Free radical attack of lysosomes is equally dangerous. Rupture of lysosomal membranes unleashes destructive enzymes, reactive species, and free iron into the cytoplasm.
So for those of you who don't think about cells every day like I do, hopefully that's kind of illustrative. This is again from the European Leukemia Net MDS registry. And so they looked at labile plasma iron, whether they could correlate that to clinical outcomes. So the top curve, the people with the best outcomes are transfusion independent and have undetectable LPI. Worst outcomes, transfusion dependent, detectable LPI, The other two groups had an intermediate survival. So, a few years ago, I was asked to give a talk, what should be the targets of iron chelation therapy, and so the clinical endpoints. And so when we're thinking of endpoints, of course, we have to think about starting points, and there's no sort of consensus on what defines iron overload and what defines iron overload severity. So this is adapted from some proposals from the Japanese, who proposed ferritin level as severity measures. I've incorporated transferrin saturation over 80% to include severe or detectable LPI, as well as imaging of the heart and the liver, which can quantify iron overload in those organs, or measures of dysfunction in the organs, as the little arrows underneath are pointing to. So in terms of so this is a 75-year-old man who has seronegative arthritis, fatigue, and his hemoglobin is 95. Bone marrow shows MDS with RS SF3B1. He's IPSSM low risk, which gives a median overall survival of 6 years. Ferritin is 1500, transferrin saturation 40%. He's transfusion independent. EPO level is 120. He's going to start EPO therapy. And so if we look at my proposed criteria, although the ferritin puts him in moderate iron overload, others put him in mild, other indicators put him in mild iron overload, and he doesn't have organ damage. So, so we would not chelate him at that point. So 6 years later, he's age 81. He remained transfusion independent on EPO for 4 years, another 2 years to luspatercept, requires 2 units every 4 weeks. Repeat bone marrow shows IPSSM moderate low risk, which has a median overall survival of 4.6 years. Ferritin's 2700, TSAT is 85%, so that puts him in the severe iron overload category. His renal function is normal. So studies of iron overload and chelation in MDS largely include lower risk patients. There are limited data in the non-stem cell transplant setting in higher risk MDS showing it's feasible, but shorter survival and other factors make a benefit more uncertain. So we consider iron chelation when patients become transfusion dependent, transferrin saturation approaches 80%, label plasma iron is detectable, organ dysfunction from iron overload is present, and life expectancy is 3 years or more, which corresponds to IPSS-R less than 3.5 or lower risk IPSS-M. If they do have high transferrin saturation or organ dysfunction while transfusion independent, we could do phlebotomies, and that would offload iron over time, but would not suppress labeled plasma iron. So in this case, we would start deferocerox at the usual starting dose. FCT is film-coated tablet. So why? 6 months after starting deferocerox, as platelets increased to 125 from 65, neutrophils increased from 1.5 from 0.8. He becomes red cell transfusion requirements decreased by 50%. Why did this occur? Well, there's been multiple mechanisms suggested, but many of us think it's because of oxidative stress relief in this case. It does result in cellular consequences, as we saw, including activation of what's called the NLPR3 inflammasome, which is thought to be responsible for many of the classic features of MDS. It also includes DNA mutations and cell death. And in hematopoietic stem and progenitor cells, these events could contribute to cytopenias and possibly malignant progression. Cytopenia improvements are reported with all 3 chelators. The mechanism of hematologic improvement, as I said, is investigational. And so I'm going to show you a patient of mine. So this is a guy who had lower risk MDS. You can see he became transfusion dependent. Here his hemoglobin is fluctuating according to his transfusion. Ferritin is going up and up and up. At that time, this is back in 2003, 2005, I think, or 2004. We had under Dr. Linda Vickers, who's now not with the group anymore, a trial of deferocerox when it was newly available. And he was really reluctant to enroll. And, I just said to him, if you don't like it, you can quit the trial, but just try it. This is the first patient I treated with chelation. He started here 6 weeks later. He received his last red cell transfusion. He became transfusion independent. His hemoglobin normalized. It stayed normal for several more years until he died in his late 80s of unrelated causes. And you can see his ferritin coming down over time. It was coming down to a level I was decreasing the dose, and I was doing it every 2 days. And, I said to him, we may need to stop the medication. We don't know if this is safe. And he pounded his fist on my desk and he said, I'm not stopping this medication. So that was obviously not the usual patient, but it was the first patient I treated, and it blew my mind. So the EPIC investigators, which is a trial of deferocerox in several transfusion-dependent anemias, did a post hoc analysis where they looked back at the 341 MDS patients and had strict definitions of what constituted hematologic improvement in the red cells, in the white cells, in the platelets. And so they found there was erythroid improvement in 22%. Some got a transfusion response, some got just a hemoglobin improvement without transfusions, platelets in 13%, and neutrophils in 22%. This is the duration of response. So at a year, 60% of hemoglobin responders continued to respond, 80% of platelet responders, and the neutrophil responses had been lost. So there's several studies showing variable response rates up to 45% with iron chelation therapy. This study showed transfusion independence in 12% at 1 year. Sorry, this is very small. The median time to erythroid response with deferocerox is 3 months. With deferoxamine, it's more like 9 months, which makes sense because we usually give it over 12 hours. So it only suppresses the labile plasma iron over that period of time. And case reports have been reported with deferiprone. So several mechanisms of hematologic improvement, as I said, have been suggested, including one group that talked about alteration in the nuclear transcription factor NF-kappa B. I haven't heard much about that recently, so maybe that's fallen off. So I told you that we can't readily measure labile plasma iron in clinical labs, but we wanted to do something practical from the MDS patient registry. So we wanted to know if patients with a transferrin saturation over 80%, indicating the presence of labile plasma iron, had different outcomes than patients with a lower transferrin saturation. And lo and behold, those with a high TSAT had inferior outcomes to those with a lower TSAT or a normal TSAT. And then this is from one of our summer student projects where we saw that, this is actually from the MDS registry, where patients who received iron chelation therapy had superior survival to those that did not. Interestingly, in the TSAT analysis, we also found that there was inferior cardiac death-free survival in those with a high TSAT. And this is from the student project, who showed that the time to first cardiac event was delayed in our patients receiving iron chelation therapy compared to those not receiving chelation. This is back to the EPIC trial, and this is measurement of labile plasma iron. So at baseline, pre-dose, your LPI are detectable. Post-dose, even at baseline, they're suppressed into the normal range, and there they stay throughout. So one of the arguments against iron chelation therapy in MDS was that it takes months to years to offload tissue and organ iron. So how can chelation have a benefit within a few months? So is this a fast enough effect to result in clinical benefit? I'd suggest that it is. Now, what about cardiomyocytes? So the leading cause of death in MDS, of course, is MDS progression and progression to AML. The second biggest slice of the pie is cardiac events. This is in vitro, so this is cardiomyocytes in culture. This is with no iron loading. That shows their contractility. This is iron loaded. I'm sure you can appreciate the difference. With treated with deferoxamine, which does not cross cell membranes well, you don't see much improvement. Deferoprone, you start to see an improvement, and deferasrox, it comes back to normal. This is just after 60 minutes of incubation. So that's cool. So yeah. Okay, so this is an electron micrograph of a normal cardiomyocyte. This is the nucleus. These are the myofibrils, which do the contractility, so your heart can pump. These are the mitochondria, which are the powerhouses of the cell. You can see that everything looks nice and orderly. This is an electron micrograph from a patient, a thalassemia patient with iron overload in the heart. And so I think you can appreciate the difference and what you would prefer your heart cells to look like. There's only one randomized controlled trial of iron chelation therapy in MDS. So this is kind of the gold standard trial. Because of people's reluctance to enroll their patients on the trial population was reduced by 2/3. And that's because people like me who believe in the power of iron chelation therapy didn't want to randomize our patients to placebo. People who didn't believe in it didn't want to enroll their patients at all. So it was reduced to 1/3 of the patient population. The mean age of the patients was 60 years, so much younger than our usual patients. And half of placebo patients dropped out and subsequently went on to receive chelation. Despite that, the investigators did show a significant difference in event-free survival, which seemed to be driven by cardiac events, as I'll show you in the next slide. So hospitalization for congestive heart failure and worsening of cardiac function. Guidelines recommend chelation after 20 to 50 units or ferritin of 1,000 to 2,500. The higher ferritin cutoffs are influenced by increased ophthalmologic eyes and ears toxicity with deferoxamine at ferritin less than 1,000. But we've observed that patients commonly receive deferoxamine to ferritin less than 1,000 without such reports. So we consider the rate of accumulation, pre-existing organ dysfunction, and oxidative stress indicators. And for many, starting chelation at moderate iron overload is reasonable. Recognizing that the chelator type and dose may be limited by side effects and pre-existing comorbidities. But since labeled plasma iron rapidly becomes undetectable with deferasrox, achieving a ferritin less than 1,000 or a normal transferrin saturation may not be required for clinical benefit. And some studies suggest any degree of iron chelation therapy is beneficial. I'm just looking to see if I have that curve here, but I don't. So the group Francophone de Myelodysplasie did a study of their patients, and they showed that those patients that received adequate chelation, which was any of the chelators according to recommended doses and schedules, had the best survival. Those that received no chelation had the worst survival. Those that received what they called weak chelation, which is intermittent boluses of deferoxamine, which shouldn't do anything, actually had an intermediate survival. So it seems to be doing something. So proposed response criteria for treatment of iron overload in MDS. This is what I use. I have to say that these criteria that I'm showing you have not necessarily been widely adopted, but it is early days. So 3 approved chelator, 2 oral deferasrox and deferoprone, and 1 parenteral deferoxamine. Deferoxamine has been used for decades, and as I said, had a profound impact in the hemoglobinopathies. But because of a short half-life, 5 to 20 minutes, it requires lengthy parenteral infusions. Deferasrox is once daily oral, and it's our first choice when it's feasible. Dosing monitoring and side effect management are included in at least a couple of review articles I've written, including the article that accompanied this education session. So this is a different guy. You can tell because he's got a mustache. He's 75 years old. He's got MDS with multilineage dysplasia and ring sideroblast. He's IPSSM lower risk, which gives a median overall survival of 6 years. He's received 35 red cell units at 3 units per month. His ferritin is 3,000. TSAT is 70%. He's got shortness of breath on exertion, chest crackles, and peripheral edema. And his NT-proBNP, which is a measure of whether or not you've got congestive heart failure, is high, which is bad. So he's got severe iron overload. EPO, then luspatercept, did not reverse transfusion dependent, and his GFR, a measure of his kidney functions, is decreased. So I've given him peripheral edema here. So he's got severe iron overload and he's got organ dysfunction due to iron. So iron may be contributing to his cardiac morbidity. Transfusion requirements are high. MDS-directed treatment options are limited. We do a baseline MRI to document cardiac iron, but not delay iron chelation therapy. And we'd also do an echocardiogram and refer him to cardio-oncology. So for GFR less than 40, we can't use deferasirox. So our options are deferoxamine, deferoprone. Our preference is deferoprone. You remember that I told you that deferoxamine does not cross cell membranes readily. Deferoprone does. This is off-label use in MDS, but it does chelate intracellular iron. So although we prefer to start with 1 chelator at a time, combining chelators may potentiate cellular iron egress by what's called a shuttle effect. So the deferoprone grabs the iron, shuttles it out of the cell, the deferoxamine takes it, and off it goes. The deferoprone goes back in. So I also have to say, if you use deferoprone during the day and deferoxamine at night, then you've got 24-hour suppression of labile plasma iron. Deferoprone has a relatively short half-life. It's given 3 times per day. So deferoprone is not approved in MDS, given its potential for causing agranulocytosis in 1.5% of patients. But there was a registry study done on 115 MDS patients showing agranulocytosis incidence was not significantly increased. So in thalassemia, deferoprone is superior at reducing myocardial iron and improving left ventricular ejection fraction, whereas deferasirox is also effective. With short-acting deferoprone, NTBI rebound at night. That's just what I said about deferoxamine. We do have to do baseline ophthalmologic and hearing tests and repeat sufficiently to ensure stability. So with deferoxamine, the other thing to note is infusion should be stopped during infections because deferoxamine binds iron in a way that's accessible to microorganisms, including bacteria, viruses, and fungi that can encourage their growth and replication. That's not the case with deferasirox or deferoprone. And so we need dose adjustments for low kidney function. So on deferoprone, 1,500 milligrams 3 times per day, his ferritin decreased to 900, crackles and edema resolved, and BNP and LVEF normalized. So he's now mild iron overload. He's had a very good partial response. If deferoxamine were used in combination, should be stopped because his ferritin is less than 1,000. Deferoprone should be dose reduced, and later the ferritin is 450, which is negligible iron overload, and we hold the deferoprone. I do have to say that our outcomes in most patients are not quite this rosy, but this is a real patient for my colleagues, so it can happen. So there's the criteria again showing where he is, and that's when we dose reduce and stop. This is from a scientist called Francesca Vinci, who is quite brilliant and has written a review article based on experiments she did in mice showing all the mechanisms by which iron overload may promote atherosclerosis and then thus cardiac events. And so this again is our prolonged time to first cardiac event in the summer student project in patients receiving iron chelation. And we showed that the same held true in patients over 75 years. It was also significant in a multivariate analysis. We showed a similar trend in infections. So the patients receiving chelation had a delayed time to first infection. The number of infections were the same between groups, the severity of infections, the type of infections, but they occurred later in the patients receiving iron chelation. And this is patients with low marroblast count. We see the same effect. Oh, so this is the French study that I was telling you about, comparing adequate chelation to no chelation to weak chelation. You see that intermediate survival. So these are the endpoints around iron overload and MDS that are addressed in clinical studies. So overall survival in retrospective studies and a matched pair analysis, leukemia-free survival, progression-free, event-free survival in a randomized controlled trial, cardiac endpoints, hepatic endpoints, infections, and hematologic improvement. So iron resultant oxidative stress affect macromolecular and cellular function. Data from randomized controls trials are limited, but excess iron associates with inferior clinical outcomes and its reduction with superior outcomes. And a deeper understanding of iron physiology may benefit transfusion-dependent MDS patients. That's just a flow chart in one of my review articles about when to start and stop different agents and switch to others. And this is another review article I wrote. This is in the circle showing MDS pathophysiology. The blue squares are where iron overload impacts on progression of MDS, and these are specific somatic mutations in MDS and, showing where they sort of feed into this pathway based on what's in the literature, which does not address all somatic mutations, and this is based on preclinical data. So current chelators have administration challenges. Further MDS-directed treatments to reduce red cell transfusion requirements are needed. Chelators with convenient dosing and reduced toxicity are needed. This is some future directions. I wanted to talk briefly about a couple of things: new iron chelation formulations and the iron overload mouse model, as well as calcium channel blockers. So these are my collaborators at the Center for Blood Research at UBC. And so they've bound iron to this high molecular weight polymer, which circulates for a long time, and it increases the half-life of deferoxamine from 5 to 20 minutes to days. And so they've shown in preclinical animal studies that this can effectively offload iron with less toxicity. The difficulty, of course, with this is that you need a pharmaceutical company to develop it. And so wouldn't a sub-Q injection twice per week be so much more convenient than a 12-hour subcutaneous infusion? They're also working on organ-targeted chelators, so they can also bind things that target it to specific organs to their molecule. And there's also a new oral iron chelator in development, as I showed you in our upcoming clinical trials. So this is from a recent study in Blood by Francesca Vinke's group already. It's called Genetic Iron Overload Aggravates and Pharmacologic Iron Restriction Improves MDS Pathophysiology in a Preclinical Study. And that's my commentary on it. Iron accelerates MDS progression. So they had this MDS mouse model, which has a ferroportin mutation. So ferroportin is the molecule on the cells of the GI tract that imports iron. And so this mutation causes it to import more iron than you would regularly get. This leads to iron overload, which they showed decreased erythropoiesis, decreased survival, decreased leukemia-free survival, and also increased reactive oxygen species. These are some of the mechanisms by which these effects may happen. Vimifeport, which is an oral agent that blocks ferroportin, blocked these effects. So this is not yet available for humans. We're only able to give it for mice. So I think that this is important because it actually shows, not just sort of one part of the story in each different study, but sort of an overall study, but also it gives a model for investigating not only iron overload, but some of the somatic mutations, for example, in MDS. Just turning back to the heart, I'm in my last half dozen slides. And yes, I am going to go over, sorry. So transferrin generally binds iron. Transferrin-bound iron is taken up in a regulated manner, released into the endosome and then into the labile iron pool. NTBI is taken up in an unregulated manner. And in the cardiomyocyte, there are 3 receptors, including one called ZIP14, where it just enters the cell willy-nilly. It expands the labile iron pool. We talked about how it damages lipids, proteins, and nucleic acids. So some of the nucleic acids and lipids and proteins that are very important in the cardiomyocyte are in the mitochondria. And so we have more mitochondria and cardiomyocytes because we need lots of energy to make the heart cells pump. And of course, proteins that are important are the myofibrils, which are the proteins that cause contractility. So, could the damage to these lead to clinical cardiac events? I'd suggest that it could. This leads to a preclinical study a couple of years ago at ASH. There's this NTBI receptor called ZIP14, as I showed you. They showed that calcium channel blockers inhibit NTBI uptake via ZIP14 and showed a dose-related inhibition. So we looked at our transfusion-dependent MDS patients and looked at whether they were on calcium channel blockers for other reasons versus other medications. And we found that in our patients on calcium channel blockers, there were no post-transfusion cardiac events compared to 43% in those receiving beta blockers and 27% in those receiving neither. So beta blockers have very well recognized cardioprotective effects, but something's happening in the calcium channel blocker group. And so this led to longer time to first transfusion-dependent cardiac event, which was statistically significant. So caveats, small number of patients. So I'm, not encouraging anyone to run out and say, put me on a calcium channel blocker. But I think that if you are on one, you can maybe be reassured in early investigation. So cells expressing ZIP14, not only cardiomyocytes, but also macrophages and adipocytes, which are cells of the bone marrow microenvironment that interact with hematopoietic stem cells and support their maturation, hepatocytes in the liver, and pancreatic insulin-producing beta cells. So these all could be affected by non-transferrin-bound iron, and all are cells of concern. And so this is undergoing verification in larger numbers from the Canadian MDS Registry. So I'm going to give the last word to the chair of this session. So iron toxicity is related to reactive iron exposure of tissues over time, which is really the take-home message. So we don't have enough medications to decrease transfusion requirements in MDS. Transfusional iron overload is a problem. Current iron chelators are not perfect, but even weak chelation is associated with survival benefit. This may be by intermittent blunting of oxidative stress, and organ protection with organ-targeted agents may be an option in the future. We did put Canadian guidelines for management of iron overload in MDS online called the MDS Iron Road, and these are just some acknowledgements.
Does this information related to iron toxicity apply to high-risk MDS patients who have undergone stem cell transplant and are experiencing secondary poor graft function and are requiring transfusions?
Yeah, I'd say yes, and I'd say it applies even to stem cell transplant patients who become transfusion independent. And so that was the second talk in this session was by my colleague Emmanuel Angelucci, who talked about iron overload around stem cell transplants. So his summary article is available on the American Society of Hematology website. And also I wrote a review article a few years ago on iron overload around stem cell transplant. So there's some very, sort of interesting work. Again, it's not randomized controlled data, but I do think that addressing iron pre-transplant, trying to minimize it, during transplant is very investigational. It should be done in a clinical trial, and post-transplant management of iron overload, I also think is important. Yeah.
I'm starting with the transfusion at MDS next week. I mean, does that mean that I'm going to be candidate down the line for iron? Yeah. Absolutely.
And so, you know, when things are going smoothly, the usual one we start with is deferoxarox. And so the hematologist, the local hematologist will start to monitor it, and everyone knows how to do that. When things aren't going so smoothly, often the hematologists refer patients to me. I inherited what we call the home hemosiderosis program, which administers deferoxamine, but I've also treated several patients with deferriprone as well. But there are, you know, like I said, future chelators coming to, not quickly enough, just like future treatments for reducing transfusion requirements in MDS. But yeah, it is. So they will intervene sort of at the appropriate time. So they won't necessarily start right away when your transfusion starts, but hematologists are very well aware of iron chelation therapy.
Not monitoring,
Yes, yeah.
depending on things are going well, you said, what does that mean?
So if things are going smoothly on deferoxarox,
I thought you said at the beginning, deciding whether to do that, if things are going well.
no, what I was meaning to say is that when things are going smoothly on deferoxarox, then the local hematologist will manage that, and it does go smoothly in many patients. But if you know you run into problems with deferoxarox, that's when they would ask me to see a patient to.
Right away, or
Right. And so there's no consensus on that. The guidelines recommend anywhere from ferritin over 1,000 to ferritin over 2,500. It really depends on the rate of transfusion dependence and also on comorbidities and renal function and stuff like that. So it's not kind of an easy answer, but you can feel free to, you know, print off my ASH education session and show them the tables that talk about, you know, mild, moderate, and severe iron overload. Yeah. I have to say, this is not something that's taught well in hematology training. You know, when I was going through hematology training, I heard not one word about iron overload. And I think that there's a real disconnect between the hematologists that treat the people with hereditary anemias in many centers and the hematologists that treat patients with disorders such as MDS. St. Paul's is one of few centers in the Western world where we see the entire spectrum of patients from benign to malignant. And so my senior colleague, Linda Vickers, sort of had the wisdom to take the lessons learned from the benign and apply it to the malignant. And that's what enabled us to do that students project way back in 2006 that showed the better survival in patients receiving iron chelation therapy, and things just sort of went from there. So, you know, I do think that current my generation of hematologists are aware of iron overload and iron chelation therapy, but the comfort level with it may not be as high as with other therapies. And, you know, keeping in mind that my generation is training the next generation, this may take a while, but I think that that's the importance of sessions like this at the American Society of Hematology. Yeah.
Okay, we'll just do another question from online to you. How long could
Deferoxarox
be used safely at a lower dose in patients following stem cell transplant?
Yeah. So, you know, that's kind of an unanswered question. So, you know, I would, if it were me, and I'm not your transplanter, but if there is iron overload present, I would probably, and if you're transfusion independent, I would probably continue a low dose until a transferrin saturation is less than 80%. And then you can even consider, you know, if your graft function is good, reducing iron by phlebotomies. That's certainly been done in the past. Yeah.
Over to you, Mary.
Yeah. Okay, so I just want to do a little summary here. So for watching for iron overload, ferritin above 1,000, GFR, comorbidities of the patient, amount of units for
Yeah.
for transfusion And you said transferal of something just. now.
Transference saturation.
Transference saturation. Now, can you tell me, because I'm not that smart, is that a blood test?
It is a
that-
blood test. Yeah. It's readily available, and I would encourage people to get it at the same time as they get their ferritin level done. Yeah. Which is not, with every blood test, but every once in a while. Yeah. It depends again on your rate of transfusions and iron accumulation. I'd say every 6 weeks to 3 months. Yeah. Sorry, I was going to say something else, but in my jet lag brain, I lost it. It'll come back.
Okay, another question here is, can nutritional adjustments such as consuming less iron-rich food and drinking tea or coffee with meals reduce iron ferritin?
It's a really good question. First, I'm going to come back to the thing that I forgot with you. So the GFR is not a measure of iron overload. The GFR is a measure of kidney function. Yeah. And whether it can tolerate the chelator. Yeah. So should you eat less iron in your food? So in the GI tract, unless you have a ferroportin mutation like Francesca Vinke's mice, which you don't, the absorption of iron is about 10% of what you take in by mouth. So it's really minimal. So by far and away, the major mechanism of, accumulating iron is through transfusions. So, it doesn't hurt to, sort of limit red meats and so on. But I think you'll find in Western diets, it's iron is a supplement in pretty much everything. I would say, check your multivitamin and take one without iron. That's one thing you could do. I think there was one over here.
I have a question. From your experience, have you seen patients who drops hemoglobin as after starting the iron chelation, just starting, and then overall they show like hematology improvement?
So whose hemoglobin increases after iron chelation?
Yes. When they just started the iron chelation, they decrease the hemoglobin at the beginning, and then they can show like this.
Right. So I haven't seen anyone's hemoglobin drop with iron chelation. I have seen it improve as I showed you, but hemoglobin drops are more likely just due to the transfusion requirements. That brings me to another thing. I'd really encourage all of you to track your transfusions. It's not really easy to track people's transfusions. Blood banks may be in different jurisdictions. So I just say keep a transfusion diary. My hemoglobin was this on this day. I got this many units.